morning, everybody. How are you all? That's great. My name is Stuart Schlossman. For those that don't know, yes, I too have multiple sclerosis. Today's program, we fortunately get lots of grants to do our programs. The pharmaceutical industry loves MS Views and News for the types of the programs that we're providing, the speakers that we bring in for our programs, and the audiences that we do have at our programs. So for today, I would like you all to help me thank Sanofi-Genzyme for doing today's program. Woohoo! Okay? Great. All right, and other than Sanofi-Genzyme, we did have a lot of exhibitors outside. I hope you got to see them, and I hope that you were able to obtain information from them that you may not have already known. Today's program, we do have some slight changes. So originally we were going to have Dr. Berkovich, but she couldn't be here today. So we brought in Dr. Ansari, and he's here to work with us today. Dr. Ansari is an MS Fellow at the USC Keck School of Medicine in LA. So he completed his medical school at the University of Texas Medical Branch in Galveston, Texas, where he graduated in 2013. He continued his training at USC Davis Medical Center in Sacramento, California, where he was awarded a chief residency in neurology and graduated this past summer. Yay, congratulations. Okay, Dr. Ansari has a particular interest in comprehensive care in MS, community, and how MS affects certain populations. So let's welcome Dr. Ansari. Thank you.
Well, thank you, Stuart, and thank you, everyone, for inviting me to speak today. It's a great honor to be here today, and I'm not Dr. Berkovich, but I'm going to do my best impersonation. Which I've had the fortune of working with her over the last several months. So essentially, I was asked to speak today about the Comprehensive MS Center, and this is something that's very near and dear to my heart. It's one of the main reasons that I went into this field to study MS. So, one thing I want to point out, I recognize some faces out in the crowd. It's very nice to see you all, and looking out at this crowd also, I see that it's a very diverse crowd, and I'm so impressed by patients with MS. Every day, I see what you guys go through, the caregivers, what you guys go through, and I think that that's what drew me to this field more than anything else, was seeing the determination, seeing how educated everyone is about their condition, how you guys come out for events like this to learn more about the disease, and seeing that motivation, really gets me motivated every day to learn more and more about the condition. And so with that, I'll go ahead and talk a little bit more about the Comprehensive MS Center, which, like I said, is something that's very important to me. So you may be wondering, and many of you may already be visiting a Comprehensive MS Center, so this question may have been something that you thought about before, but why should I care about being seen at a MS Comprehensive Center, versus being seen, by an MS specialist out in the community, or by being seen by a neurologist out in the community? What is it that makes a Comprehensive MS Center special? So I think the first thing that we need to address and get out of the way is that MS is a very unique disease, and it affects different people differently. And that's it's a subtle point, but it's something that's very important to talk about. And that's that no two people have the same symptoms and have the same experience with MS. And so it's only natural to think that you've gone through the diagnosis period, you've gone through seeing multiple physicians, getting referrals to see different specialists, going through such extensive testing, that one person is not going to be able to handle this disease. One person is not going to be able to address all the symptoms that you have. And so for that reason, it's very important to have a team approach and have multiple people that you can talk to about your condition, about the symptoms you're experiencing. Secondly, there are different stages of the disease, as many of you will already know, and your goals and your approach to the disease is going to change along with the disease. Early on at the time of diagnosis, your focus may be more, okay, how is this going to impact my life? How is this going to change what I'm already doing, my career aspirations, my aspirations for having a family? As the disease continues and with the different stages of the disease, whether it's, dealing with progressive symptoms, whether it's dealing with, bladder issues, whether it's dealing with fatigue as becoming the primary symptom of MS, your goals and your approach to the disease also changes. And so, again, having one person manage all of those things doesn't make any sense. It makes sense that early on in the disease, you may need to speak to a social worker, you may need to see a neuropsychologist, and then later on in the disease, it may be that your focus is more on therapies and physical therapy, occupational therapy, things like that. And so that's why it's so important to have this broad team. And I'll go over the details of the individuals in the team, but I think it's very, very important to have this sort of team-based approach. There's so many different MS drugs. I've lost count now. I don't know if it's 14 or 15 now, but it seems like every few months they're coming out with a new drug, and that's great. That's something that also drew me to the field, was that there's so much potential there for treatment. It's a devastating disease, but we're making progress with it, and I think that when you have so many complicated drugs, it's important to have a pharmacist there who you can speak to about side effects of different medications. Your MS specialist who understands all of these drugs. Having a research team at the institution that you're at that is investigating new drugs and investigating how the drugs that we currently have affect different populations. Because, as we can see around the room, MS doesn't look the same for any two people. Kind of along the same lines with regards to the research, there's so much research going on in MS. I've spent some time in the last 5 or 6 months just studying this disease and only this disease, and I've been to conferences, I've been to different courses, and you see out there's so much active research going on. And as a patient, part of the experience and part of what hopefully motivates you to keep doing what you're doing and living the best life that you can with this disease is that there are people out there who are trying to make the condition better, make it more manageable, and hopefully find a cure. We're not there yet, but hopefully find a cure. And you want to be along for the ride. You want to have a front row seat to that. And if you're at an institution that has a comprehensive MS center and has an active research going on, then you're going to be the first people to hear about these new discoveries and these new advances. You want to be taken seriously when you have a question, and this is, again, a more subtle point, but people have different experiences wherever they go. Whatever physician they see, whatever specialist they see, they have different experiences, but MS like we said, is a very unique disease, and early on in the diagnosis period and soon after diagnosis, you may be left wondering, every symptom that I have, is this my MS? Or is this normal? Or is this something else that I might be dealing with? How do I know? How do I navigate this time when I have a little bit of tingling? I'm more tired today than I was 2 days ago. Is this my MS acting up? It's so difficult to kind of wade through that when you're dealing with a new diagnosis, and I'm sure even after years of having the disease. And so it's important to have a team that's there that has experience with the disease, have different expertise. Sometimes the specialist may hear about the symptoms, but your MS nurse or your MS nurse practitioner you may feel closer to in dealing with a certain symptom that you've been having for a long time and talking to them over a period of weeks or months. It's important to have that connection with your MS team and to have that point of contact that you can talk to. And then lastly, and most sadly, we talked about this, but there's no cure for MS, and you have day-to-day symptoms, and so that may affect your quality of life, and it's important to have a team-based approach and many different people who are all trying to figure out what's the best way to treat you and what's the best way to be a partner with you in getting through this disease and getting through each day, essentially. So, okay, the next question is, who is part of this comprehensive MS center? Who makes up this team? And I was asked to speak on what constitutes a core team of MS and what constitutes the extended team. But I think that that's probably not the best way to think about this. At USC, many of the people in the MS, comprehensive MS center are all in-house. They're all in the same location physically. I can walk down a couple doors and talk to the research coordinator. I can talk to the neuropsychologist. I can talk to physical therapy. That may not be the case everywhere, and some of this is resource-driven. Some of it has to do with space and physical limitations and things like that. And so there's no one right way necessarily, although I'll argue at the end that there might be a better way. But there's no one way of doing things. But so this concept of the core team versus the extended team, it may not be that important to delineate, to make that distinction, but I'll go ahead and talk a little bit about what makes up each team. And so the core team, in my mind, that's going to be you, the patient, and then the people that you see at every visit or at any given visit that are there physically in the clinic that you can reach out to and talk to about how your MS is doing. And you have that kind of one-to-one communication with. And that's going to be your MS specialist. That's going to be your MS nurse, and in some cases, that's going to be your MS nurse practitioner. So your MS specialist, who is this? This is going to be your MS physician, your neurologist who's had special training in MS, or at least has a lot of experience or exposure to the condition. This is someone who is trained in the diagnosis and management of MS. So this is going to be the person who reviews your MRIs. This is going to be the person that you have a visit with every 3 to 6 months to talk about how your disease-modifying therapy is going, how your symptoms are going. This is going to be someone who hopefully is your biggest advocate. And I can't stress that enough, that while it's important that this person may more than likely be kind of the head of your comprehensive MS team. This is the person who kind of coordinates everyone within the team. But that's why it's even more important that this person is your biggest advocate. This is the person who wants to see you get better and wants to see you achieve the goals that you've set out for yourself at any given point in the disease. Your MS nurse. And so this is someone, depending on where you receive your care, who's going to be your first point of contact. You're going to know them on a first-name basis. You may even have their phone number or their extension, on speed dial on your phone. And that's someone in our clinic. That's Kathy. I know her. She's someone I'm very close with. She's someone, whenever I have a problem, I'll say, where's Kathy? Let me ask her what's going on with this patient. How can I get a hold of this patient? We need to address this issue. And so that's an important part of the comprehensive MS team, and I think that's why I include the MS nurse as part of the core team. And so this is someone who is going to have special training in MS. They've gone to nursing school, they're a nurse by trade, but they also have special expertise in MS, whether that's by experience, whether that's doing certain courses. And they need to be knowledgeable about the basic signs and symptoms of MS, so that when a patient does call or when a patient does send a message with the new kind of portals that a lot of hospital systems are using, that they can direct you on where to go. Sometimes they might be able to give you a call and let you know exactly what you need to do in that situation. Like Dr. Amesquis was saying earlier, the call may just be, so-and-so has a fever and so-and-so has these kinds of symptoms, and the MS nurse may say, you need to call your primary care doctor for this. Let me send a message to your primary care doctor. That may be all that's necessary, but it may be more complicated than that. You may be having issues with insurance, you may be having issues with getting certain labs, or when you have your follow-up, and your MS nurse can coordinate kind of all of that within the clinic, and that's a very important thing. Your MS nurse can also advise you on what constitutes a medical emergency. So if you call and you're in a situation where you feel really bad as a patient with MS, and you are having new symptoms that you've never had before, or you're having a lot worsening of your symptoms and you don't have anyone who can help take care of you in that given time or time frame, they're the ones who are going to tell you need to call 911. What can we do to help kind of facilitate getting you to the hospital? And that's an important person to be familiar with and to be in close contact with throughout the course of your disease. And lastly, this is someone who can help facilitate your MS care by helping to navigate and coordinate, what medication you're on, whether you need certain labs monitored, where you got the labs done, how to get those records, and things like that. And then the last person who's part of the kind of core MS team is going to be your MS nurse practitioner. And so, again, not every institution has a nurse practitioner, but I would argue that it's a very valuable member of the team. And this is going to be someone who is a nurse by trade, but then has undergone additional training specifically to be a provider, to be able to address the questions that you have and take care of symptoms that you're experiencing. And this is someone who can also help you when you have something that comes up urgently and you can't get in to see your MS specialist because their schedule is booked up for 3 or 6 months in advance. This is someone that you can get in with within the next week or two, who can address new symptoms you're experiencing, or if you're feeling any worsening. And so that's what makes them very valuable. Also, if you're having a question that needs to be answered and your MS nurse may not know the answer to this question because it's more detailed than something that they have experience with, your MS nurse practitioner can be the next person in line. And at USC we have Leslie, who's our nurse practitioner, and she's so knowledgeable about the condition. I often find myself asking her, Leslie, I have this patient who's having this symptom or this problem. How have you dealt with this before? And she'll say, 10 years ago we did this, and now we're doing this. And it's so refreshing to have that person in the clinic who's very approachable and who can help with these kinds of situations. So that's a little bit about what I would consider the core team, but there are so many other players in the comprehensive MS team, and I think this is what has been kind of a paradigm shift in the care of MS. And what got me really interested in the condition was the fact that there are so many people involved as well. And I saw, this was something that in residency and in medical school, I saw other conditions have this kind of team. I saw other conditions, in neurology training, I saw, patients with ALS or patients with Huntington's disease. They have these kind of centers for excellence. They'll have these clinics where they'll have, a patient will come in and they'll see multiple providers and they'll have all of their questions answered, all of their issues addressed all in one visit. And this was, this is something that I think is kind of the future in terms of the care of MS. And that was something that I thought that, if they can do it in those conditions, MS is a perfect place to implement this kind of center, because there's even more hope for treatment. There's even more things going on actively. And so we'll talk a little bit about each of the members within the extended team. And so the first person that I want to talk about is going to be your MS physical therapist. So this is going to be someone who's physical therapy trained, but has a specialty training in neurology. I hear all the time from patients and from caregivers, we tried physical therapy, it just didn't really do anything for me. I didn't feel a connection to this person. I didn't feel like they knew MS. I'm sure they're trained, but they don't understand MS. And I think that's why it's so important to see someone who is trained in neurology and who has experience with patients with MS. And that can go a long way. At USC we have Nora, who's our MS physical therapist. She's in our clinic. She's made herself available to patients after our visits to introduce herself and to try to get a sense of what each patient needs in terms of their therapy needs. And oftentimes people live far away. They can't come to USC for therapy twice a week, for 6 weeks or however long that they're doing their therapy. Well, there's the website, the apta.org, where you can go and find a physical therapist who has specialty training in neurology in your local area. And Nora often helps us try to find that person for each individual. And so that's another thing that makes them very important. But a little bit about what they do. So they're able, within MS, they're able to help with gait assessment and safety. So, falls are such a big problem that we deal with in society. And people with MS, I'm sure you guys have experienced this. Balance and gait can often be a big issue that you deal with. And, making sure that you're doing it safely. And sometimes, that involves just being mindful When you're walking, you're not doing anything else. You're not trying to juggle 10 different things while you're walking. I mean, that's good advice for anyone, but especially for someone with MS. And so that's something that the physical therapist can kind of help you in figuring out what's the best way to go about that safely. Additionally, they can guide with exercises to improve strength and balance, and so this is where they'll take you into the gym and they'll teach you different exercises that you'll do with them, and then you'll do at home, and it can make such a big difference. I remember at our retreat a couple months ago, Nora showed us a video of a patient with MS who had a foot drop. And he'd had the foot drop for several months, had not had any kind of therapy on it, and within 11 sessions, he went from walking with a limp, needing to use a cane to walk, to doing some light jogging on a treadmill. And that was 11 sessions within a few months. And that's not everyone's case. It's not going to be exactly what you'll experience every time, but that's the potential that's there with physical therapy, and that's why I think they're such a valuable member of the team. Additionally, with some of the symptoms that are more unique to MS with regards to spasticity and pain, this is where a lot of patients will tell me, I have too much pain, or I have too much spasticity to get a whole lot out of physical therapy. They just help me figure out if I'm safe to walk, but I can walk, but I have these other symptoms that limit me from reaching my potential for what I want to do, or fatigue even. And so that's why it's important to have someone who has a lot of training in neurology and in MS, because they can use different strategies, for stretching and for kind of guiding you through these exercises to try to help with those specific symptoms that are unique to patients with MS. And then lastly, one that hopefully those of you who are not in a wheelchair won't have to deal with, but for those of you who are, doing a wheelchair assessment, making sure that your wheelchair is taking care of you when you need to get around, making sure that the armrests are the right height so that you don't deal with pain, making sure that your seat is properly fitted for you so that you're not slouched over and having additional pain and other symptoms as a result of the chair, even more so than just the MS itself. These are very important things. And one thing that I found very exciting, I went to the Boston home recently in Massachusetts, and they have a assistive technology program where they have a particular individual who's interested in kind of finding different devices and technologies that can help make it easier for people to use their phones, take pictures, do all these things, even with very advanced MS and being wheelchair limited. And they have these kinds of programs in other places around the country as well. I know that Rancho Los Amigos has an assistive technology program there as well in Downey, and so this is something that's very exciting to me, and I think that is important for patients to know about and also to utilize. And your physical therapist can be someone who can help you kind of navigate that process. Next, I was going to talk about occupational therapy. A lot of people say, PT, OT, it's all kind of the same thing. Well, in MS, it can be very different. The physical therapist can focus a lot more on gait and spasticity and those kinds of symptoms, but our occupational therapists often help a lot with cognitive impairment, with fatigue management. In particular, they can help physically with certain things like wrist drops and foot drops with getting you the right orthotics, but I think more importantly is kind of this lifestyle redesign program that a lot of occupational therapists are doing these days to take inventory of what your life is like, to individualize your care and find out what are ways that they can help you deal with cognitive symptoms, help you deal with fatigue in a way that will be more meaningful to you personally. They can also help with identifying accommodations for your home or your workplace. And if the time comes where you're no longer able to work, which affects a lot of patients with MS, they want to work, but they get to a point where they just don't feel safe working, or they don't have the energy to work. Your occupational therapist can really help with navigating the complex and very, very, sometimes it seems like almost vindictive disability process, where you have to specify, how many pounds you can lift and how many hours you can stand, and what positions you can work in and things like that. That's their specialty. That's what they're there for, and they're there to help you figure out the best way to kind of navigate this system as well. Your speech-language pathologist. So this is someone that may not be necessary early on in the disease, but then later on in the disease may be helpful for those people who end up having difficulty with swallowing or difficulty with language and kind of information processing speed, kind of going along with those cognitive symptoms. They kind of have that twofold approach, and this is going to be the people we technically refer to as their speech therapists. And so with swallowing, they can do swallowing evaluations to see if there's any maneuvers you can do, like the chin tuck or turning your head to one side to try to help get food down, but also giving advice on what type of diet texture you can best utilize to try to stay eating and stay as independent as possible, but at the same time not making your symptoms worse. And then with regards to the cognitive symptoms, they have special programs for cognitive rehabilitation that speech therapists often lead in coordination with occupational therapy to try to get the most out of helping you manage cognitive symptoms with MS and hopefully finding solutions to stay independent and get through each day. Your social worker, so this is someone that I think plays a key role after diagnosis, someone that you can talk to, someone who can let you know about the different programs available, the different websites that we have, for different organizations like MS Views and News, like the National MS Society, and trying to find out the best ways to navigate all of this process and figure out the best way to individualize how you're dealing with the MS. And one other thing that they do that's very important is that they often lead support groups for patients with MS and also caregivers who have MS. I know that at USC, Kara is our social worker, and she leads a MS support group, and that's something that a lot of patients have expressed interest in and have found helpful. And so that's someone who's a very key player in the comprehensive MS team. Your pharmacist, so this is something that I think is new to MS, that we have MS-trained pharmacists, people who went to pharmacy school and then in particular have a particular interest in MS. And I think with all the drugs that we have in MS, it's very, very helpful to have a pharmacist who knows the ins and outs of each of these drugs, the different side effects, what patient assistance programs are available for the different drugs, how much a drug may cost, whether there's a generic available, things like that. What's the latest research on, patients who've had a particular complication from MS? They also have different kind of relationships with the pharmaceutical companies and some of their liaisons who know about kind of the up-to-date information about a particular drug and how its post-marketing surveillance is going and whether there's patients who've had certain symptoms so that they can kind of inform you on those kinds of things. And at USC, I think we have one of the first MS-specific pharmacists, but I think this is something that's going to become a big deal around the country. And so I think that's someone who's very important within the Comprehensive MS Center. Your research coordinator. So again, earlier I spoke briefly on how the importance of research in MS and being part of an MS center. Well, this is the person who is going to make sure that you get enrolled in the research study that you want to be enrolled in, that you have all the information available. I hear from a lot of patients that they want to be involved in research, but they just hear maybe a snippet about something at the end of their visit, or as they're walking out the door, their specialist may say, "Hey, do you want to be a part of my research study?" And they don't get to ask any questions. They don't get to really sit down with the material. Maybe they get a flyer or something like that, and they go home and they forget about it. No one followed up with them. Well, this is kind of the role of your research coordinator. This is someone who can come at the end of your visit and while your specialist is off seeing other patients, they can sit there and talk with you about the research. They can go over the enrollment with you. They can go over the consent process with you, and they can call you if you go home and say that you want to be called back in a week or two after you've had time to digest everything, that they can get you involved in the research. And once you're involved in a trial, they can keep you up to date on any of the latest findings. And if you have any questions about when you need to get labs or samples or things like that, they can help coordinate that with you. Your urologist, so Dr. Ginsburg is in the crowd. He's going to give you guys a talk a little bit later, so I won't step on his toes at all, but just to let you know that your urologist can be a very valuable asset with regards to your MS care, and we're very appreciative at USC to have Dr. Ginsburg on our staff and so close that we can keep in constant communication with him, with our patients, and I'll let him talk more about the urologic symptoms and treatments. Your psychologist, so this is going to be someone who, like Dr. Amescuel was talking about, would do neuropsychologic testing. And so this is very important for patients who start to notice cognitive symptoms to have a baseline assessment with the neuropsychologist. This is going to be a very detailed interview where they're going to have you do various tasks and go through different tested protocols and tests that you have to do. That can take hours, but it's very important to have this as a baseline so that going forward, if you're having worsening cognitive symptoms, sometimes it can be difficult as the patient to communicate this because you're dealing with cognitive difficulties, you're dealing with language difficulties. How do you communicate this when you're having problems in the form of communication? And with the caregivers, you do the best you can, but sometimes it's hard to evaluate how something is getting worse, what domains are getting worse. Well, this is where your neuropsychologist can have an objective assessment and follow it. And if the only symptom of your MS that's getting worse is your cognition, well, that could still mean that you need a different treatment and that you need to be on more aggressive therapy maybe. And it's very easy to feel, even as an MS specialist, it's very easy to say, well, if their only symptom is cognitive, I might not want to change their medication. They're still walking, they're still able to function. This medication isn't causing side effects, I'm going to stick with it. But if there's an objective assessment of their cognition getting worse, and you can see it in the form of this neuropsychologic testing, then that's hard to ignore. It's hard to look at that and say, I'm not going to do anything with this. And so I think that's where the psychologist is also very important. So those are the members of the team, and so I think the next question is, how do you utilize this comprehensive MS team? So I think the gatekeeper is going to be your MS nurse. That's going to be the person in your phone that you're going to call anytime you have questions or anytime you need to have something addressed. But it's definitely keeping an open dialogue with your MS specialist as well, because they're going to be the ones who are going to put in your referrals and things like that. And so. I think it all comes down to communication. And then be open to ongoing rehabilitation. You may not feel like you're having problems walking, but you may have spasticity or fatigue. Our colleagues in physical therapy, occupational therapy, speech therapy, they're there to help you. They have specialty training in MS. They're not going to judge you for what symptoms you're describing, or if they feel like, oh, you're not sick enough to be in my care. That's not going to be an issue if you are seeing someone who has specialty training in MS and in neurology. Just briefly, I was going to talk a little bit about what the comprehensive MS center should look like. This is something that is going to vary from institution to institution, but the idea in my mind is that what I think would be easiest for me if I were a patient with MS, but you guys can let me know if you feel differently, is to have one place where you can get everything done. To have one place where, like I said, my neuropsychologist is a couple doors down. My research coordinator, I can just grab them at the end of the visit and say, hey, my patient has a question about this research study. Having everything in the same place, having an infusion center that's on site so that your MS specialist can come down and see you if you're having a reaction or if you're having any symptoms at that time. And that's what we're striving to do at USC. And I know that other places are striving to do the same thing as well. So, I hope that over the course of this talk, you guys feel as inspired as I am about the Comprehensive MS Center and the role that it plays for each of you that have MS and for the caregivers that are here today. And I want to thank you guys for letting me speak today.
So Dr. Ginsberg specializes, his degree of specialization is he's an MD, urology with a focus on neurogenic bladder, professor of urology at USC Keck Institute of Urology, and chief of the Female Pelvic Medicine and Reconstructive Urology section, chair of the American Urological Association Neurogenic Lower Urinary Tract Dysfunction Guideline Panel. He's chief of urology, Rancho Los Amigos National Rehabilitation Center, and he has been focusing on patients with NGB, large number of MS and spinal cord injury for over 20 years. Let's welcome Dr. David Ginsburg.
Thanks, Stuart. NGB means neurogenic bladder. Now, where is the clicker? Here we go. So, first off, I think we need to Stuart gave you a little bit of an introduction, but we need to really clarify things about where I've spent time in my training, and most importantly, where I've spent time in the Pac-12 and who I root for in college football, right? So that's LA County USC Medical Center, the old county. What you see when you watch General Hospital, that's the picture that comes up. No longer do we use that place. I was a resident there. I was a medical student there. I'm on faculty at USC. And I would say that USC probably is the last school in the Pac-12 that I root for in college football season, even though I worked there. And that's because I was born here. So who knows what that is? Also a hospital that no longer is in use. That's UCLA Medical Center, now since replaced by Reagan. So I was born at UCLA. So parents went to UCLA, they were still at school. So I grew up in a UCLA family. But that's also not who I root for. So my University of California ties go a little farther north, University of California, Berkeley, which we're not really good in sports to begin with, but I would think we're going to be horrifically bad in college basketball this year. But I'm sure all of you are wondering, what does this have to do with my bladder, right? We're going to get there. So Berkeley's not really known for great sports programs. One of the things we're most famous for is we're home of the free speech movement. And in fact, it's so important that we have the Free Speech Movement Cafe, which you can see, a prank turned into the Free Pee Movement Cafe. We're going to talk about how we can stop some of the unnecessarily free pee movement that may be happening when you have MS, all right? So why do we care about the bladder if you have multiple sclerosis, right? So we know that a significant number of patients with MS have bladder dysfunction, and in fact, the urologist or bladder symptoms leading to a urologic visit is the first doctor that undiagnosed patients may see 10% of the time. So for example, I'm at USC, so if I get a graduate student, undergraduate patient, male, woman, usually more women, men, telling me that, really, really bad bladder symptoms, I immediately start to ask about other questions. Numbness in the hands, arms, legs, and feet, visual issues, whatever it may be, to make me concerned, is there something else going on? Because you always have to think about that in the back of your mind. So what is MS? How does it impact your bladder? How can it impact? It can impact the bladder's ability to hold urine and then empty it. We're going to break that down in different ways. So to do that, though, we're going to make you all medical students for a short period of time. This is the lecture that I've been giving to medical students for a long time about how the bladder works and the problems they have. So what's the bladder function? So you got 5 steps. Bladder is going to fill. You have your iced tea, your water, increasing blood flow to the kidneys. Kidneys make urine. That urine's sitting in the bladder. And when things work appropriately, as the bladder fills, the urge to go increases. Not like, I got to go right now. We're going to talk about that. It's that urge slowly increases. And you're going to say, wow, this is the best lecture I ever heard. I'm not going anywhere. And that's fine. Or you can go pee. It's all right, too. I didn't count the steps. When the urge gets strong enough, you decide to go to the bathroom. And again, You have time. And part of the issue that, you have time and you can go to the bathroom. Part of the issue that we have to deal with not only is how the bladder is impacted, but how your mobility may be impacting your ability to get to the bathroom as well, because it's a lot of things going on here, right? So the urge, go to the bathroom, and then you go. And you go when you want to go. Sometimes with MS, you can only go when the urge hits you, but you can't necessarily go when you want to go. Just, I'm going to go in the car, so long trip, let's go to the bathroom now. And when you're done, you have emptied your bladder out completely, okay? That's normal. Someone said no. I'm sorry. So let's break this down. How do things mess up? Bladder fills. Well, maybe when your bladder filling, you have a poor sensation of the bladder filling at all. You don't know the bladder's filling. You can get a whole bunch in there and you don't know what's going on. So you can have a sensation that happens too early. So you have too little in there, really, but you got to go way too soon, leading to having to go frequently. Or you never know when your bladder's full. You have urge. So the urge to void, I asked the medical students this yesterday about 4:30. I do the Friday afternoon lecture every 6 weeks of the surgical subspecialty lecture. What's normal? Who has urge? And they raise their hand. I said, who has urgency? And they raise their hand. I go, what's the difference? I don't know. The urge is normal. That's normal. A normal sensation of bladder filling. Urgency is, I have to go right now. And if I don't go right now, I may feel like I have an accident, or you may have an accident. A lot of people shaking their heads. So urgency is defined as a sudden, compelling desire to void. That definition used to include a sense of incontinence. It's just, you got to go right now. BR, bathroom. You go to the bathroom. What may be abnormal is, before you get to the bathroom, you had an accident, right? That's the picture. Got to go right now. The problem is, this patient is running, and if you have MS, you may not be so mobile. Again, compounding the issue, right? And you go. You urinate. You pee. Pass your water. Whatever you want to call it. But with MS, part of the problem is you feel that urge, and you go sit down on the toilet, and nothing happens. Like, what the heck? Got to go. Nothing happens, right? And the goal is you empty out completely, but everyone doesn't empty out completely. So again, those are the things that we deal with when you're in my office. That's a normal bladder. So bladder fills, contraction occurs, and you pretty much empty out. So what's pathologic? Well, normal bladder, but then you have this called overactive bladder, a premature bladder contraction. You can call it a bladder spasm. When I talk to patients, I often refer to it as a bladder spasm. When you're talking to other physicians, one of the terms we may use is detrusor overactivity. That's a urodynamic term. I'll talk about urodynamics a little bit later. That just essentially says that bladder is contracting without your permission. Okay? So this is the bladder contraction that occurs when you want it to. That's normal. But what can be happening is this same bladder contraction is now occurring when your bladder is way emptier than, not full as it should be, and then you just got to go. And you get that urgency, right? Not the urge, the urgency. So what is neurogenic bladder? Stewart said NGB, neurogenic bladder. Very generic term. Means you got a problem with the bladder, problem with the outlet, your sphincter, or both. And you got to have a neurologic diagnosis. So because I'm a guy that sees a lot of neurogenic bladder, doctors send me patients with neurogenic bladder all the time. And I'll start talking to them and go, what's your neurologic problem? They look at me like I'm crazy, man. I had no neurologic issue. So sometimes that term is inappropriately used. A neurogenic bladder is not someone that has just a really hard bladder problem to treat. You got a neurologic problem. And that's easy for this crew because we know you have MS or some kind of variant. So what's going to happen when you come see the urologist, not the neurologist? So when I was a resident at LA County USC Medical Center, there was a neurologist whose name was David Ginsburg. So there was a urologist and a neurologist with the same name. So as you can imagine, when the page would come at like 3 o'clock in the morning because someone needed a catheter placed, and it went to the neurologist, he wasn't very happy. So, we're going to talk. What's going on and what bothers you? You know, I mean, Dr. Meskill kind of talked about, prioritization of issues. There are some bladder symptoms that I may think are terrible, but, so like nocturia, getting up at night. I had a patient yesterday, one of my last patients of the day. She pees every 1 to 2 hours. She gets up 3 times a night. Doesn't bother her. She's totally cool with it. Doesn't want a medication. Okay. If you're good, I'm good. There are certain things that I may find that we have to treat, but usually it's a lot based on symptoms. And we're going to see what bothers you and what are we going to treat. So we're going to do an exam, a belly exam, maybe pelvic exam, rectal exam, depending upon the patient. A little mild, somewhat of a neurologic exam, not to the extent that you're going to get at the neurology clinic, but a little bit of that. And we probably get a residual. See how much urine's left behind. So that's a little ultrasound machine that just goes over the patient's, over the lower part of the belly, and that tells me what's left behind. Do you guys have that in your office? Yeah, I mean, if you go to a neurology specialty clinic, most neurologists don't do this. You go to the MS specialty clinic, they're down with what's going on, they have it. So at SC, I know they have that. They have the residual machine. And we'll get a urinalysis at the very least. Most patients, not all of them. So what are the things we're going to talk about? So here's things we might talk about. Urinary frequency. How often do you pee? How's that urgency? Can you wait? Nocturia. Medical term for how many times you get up at night. And again, all these things is how much does it bother you? How about incontinence? Do you leak urine? Is it urge like, I got to go right now? It's what we call stress incontinence, meaning you leak if you cough or sneeze or laugh or do a pressure release in a wheelchair or pick up a grandchild, whatever it may be. Is it, I'm wet, I don't even know why I'm wet, I'm just wet. How many pads are you wearing? Diapers, how are you managing that? And what about emptying? Do you have hesitancy? Hesitancy is time to go pee, you gotta wait for it to get started. Or is the flow bad? Now how do we ask about, how's your, how do you rate your flow with, if you go to the Dodger game, next to the guys next to you? Ask the patients, if we go out to Santa Monica Beach right now, can you write your name in the sand? How's your flow? That's how we figure it out, right? Do you feel like you empty your bladder completely or not? It's amazing how, because with MS impacts not only how the bladder is able to contract, but also sensation, you may feel like you empty your bladder completely, but there could be a lot of urine left behind. So how you sense isn't always helpful, isn't always telling. That's why we always check with an ultrasound. There are bladder infections. And there are two other things that we're going to talk about. Bowel issues also play a role, and erectile dysfunction for the men, because that also can impact men with MS as well. So we're going to focus on the bladder part, not the erectile dysfunction today. So what do we do for the evaluation? Well, I love doing bladder diaries, okay? So it's going to I would say I'm giving you some homework. And here's an example of someone's homework. Here's the diary they did. So this is a sample of one of my diaries. Time you void, volume you void. So we give you a nice little, for the men, we'll give a urinal. For the women, we give you a little hat you put in the toilet seat so you can measure the volume. Are you wet? And if you're wet, why? And you're putting letters down. For you, meaning urge, S for stress, you cough or sneeze, or N for not, you don't know. So I look at this and I'm like, wow. One thing that I noticed is patient had just one episode of urgency incontinence. So she wasn't very incontinent, but one time is more than we want if we can avoid it. But I also look at these bladder volumes, 4 ounces, 5 ounces, 4 ounces, 5 ounces, very small bladder volumes. Bladder's not holding a lot. I learn a lot from a bladder diary. So there's a lot of times where we're going to use this with patients. So we do bladder diaries, we'll do urodynamics. I didn't bring pictures because I don't want to really scare anybody, and no one wants me to take pictures of them doing urodynamics. But urodynamics are extremely helpful for a lot of patients that I see, but not always necessary. There are a lot of times where I talk to patients, do an exam, get a PVR, residual, urinalysis, and we almost always will start therapy. We'll try some medications. Medications don't work, or physical therapy, whatever. We'll talk about different treatment options. But if the initial therapies don't work, I may need to do urodynamics. And it's very, very helpful to allow me to understand how the bladder is working, behaving, or misbehaving. And it just involves putting a couple catheters inside. And while we put the catheters inside and in the bladder, we can measure your bladder pressures. Then we slowly fill the bladder up. Through that catheter, we measure what's going on as the bladder fills. When you feel the urge, can you hold it? When you void? And that really helps direct care when our prior therapeutic treatments didn't help as much as we wanted them to. So what's treatment? Well, to treat, we have to figure out what you got. And there are two main problems. You can't store the urine and you can't empty the bladder. So we're going to break it down into these two main categories, all right? Unfortunately, they're not mutually exclusive, especially with MS. You can have a little bit of both. But we're going to keep it very straightforward for this afternoon and look at just you can't empty and you can't store, all right? So, 43-year-old woman. She had been diagnosed 4 years ago, but as I think someone mentioned, there were symptoms prior to that. This is often the case, right? It takes a while to get them to come to diagnosis. So what are the bladder symptoms? She pees too much, 10 to 12 times a day. When she feels that urge, absolutely can't wait. She leaks on the way to the bathroom several times with that urge, okay? So what does that mean? What does this mean? So when I mean she can't store, it probably has, I made that, told you that term bladder spasm, probably having a bladder spasm, right? So here are treatment options. So let's go through all these different treatment options. Nothing. I told you about a patient yesterday. Told me that she was voiding every 2 to 3 hours, getting up 3 times a night. Didn't bother her enough. So if you tell me you're not bothered and you don't have things like recurrent UTIs impacting your MS therapy, because there are certain therapies where if you're having recurrent UTIs, that's a big problem, right? You're not leaving so much urine behind that's going to impact your kidneys. Things that make me worried. If you're not bothered by it, I'm not bothered by it. I'm going to be as bothered as you are. If you're bothered by it, we're going to do more. It's that simple, right? Because this is, what I do is incontinence, for the most part, it's not like it's high blood pressure or coronary artery disease. It's not, no one's dying of this. This is quality of life. That doesn't minimize it. Quality of life is really, really important, but it means you're helping make the decisions. It's very much a conversation between the two of us. So, you're not bothered, we're not doing anything. What about behavioral therapy, pelvic floor therapy? So we already talked about the physical therapist. I have a list in my office of probably 20 or 30 pelvic floor physical therapists in Southern California. Because I know that everyone that sees me is not going to come to our pelvic floor physical therapist at USC. So these are not physical therapists that really focus on someone who just had a knee replacement or a bad back or a sore shoulder. And they're not working on the Los Angeles Dodgers pitching staff. These are folks that really focus on the pelvic floor. So they work a lot with urologists, gynecologists, colorectal surgeons. And they're going to help you in a variety of different ways, whether it's you can't empty or can't store, to work on your muscles to help gain control of the bladder. So what are things you do? It might be just diet management. So, great example. I wish I brought this diary. I saw a patient of Mark Liu. So Mark Liu does Parkinson's. So it's a Parkinson patient, but neurogenic bladder, somewhat similar problems in some patients. And this patient was complaining of frequency. Only, not really urgency, frequency. And he had a lot of frequency. But it kind of wasn't making sense with his other symptoms, so we did a bladder diary. He was drinking 5.5 to 6 liters of water a day. So he should have frequency, right? So I'm like, and his bladder volumes when he was voiding were like 400, 500, a very normal bladder volume. I'm like, your bladder is perfectly normal. You want to pee less? Drink less. Simple, right? So maybe it's just fluid management, but it's also things like, so the iced tea has caffeine, may not be, and it doesn't impact everyone, but we know there are certain food items that can impact certain patients. Caffeine, alcohol, anything that's spicy. We live in Southern California. We have the best array of different foods, plenty that which are spicy. I have a wonderful patient who I haven't seen for a couple of years. She has LAPD, and she loves her salsa. She has salsa breakfast, lunch, and dinner with everything. And I finally convinced her to stop eating her salsa for like 3 days. She's like, oh my God, my bladder was so much better. But I can't give up my salsa. I said, okay, well, it's up to you, right? So she cut back on it. Didn't give it up, cut back on it. So food can play a role. Pelvic floor exercises are really helpful. So, and that's where we work with the pelvic floor physical therapist. And I'm a big believer in that, so we will use that in certain patients. And again, it depends on your level of ability, disability, what ability you have, and how that can or can't be helpful. It doesn't help everybody. And everyone can't do it. If you could do this, you're good. That's a tough one, though. All right. So now, what about meds? You like that one. So we gotta lessen the urgency, right? Decrease the incontinence, increase the volume your bladder could hold, so we decrease that frequency. And we talk about expectations. My goal, when you leave the office, I want you to understand the goal is to make your bladder better, not make it perfect. If you make it perfect, that's great, but really we're just trying to make it better, because that's where we're able to get to. Very, very hard to make someone's bladder perfect, whether you have MS or not. That's what I tell all my patients, whether without a neurologic issue. So these are the medications that we use. We're going to go through these a little bit, so you appreciate that. So we have two major classes, anticholinergics. These have been around since the 60s. The top one, oxybutynin, came out in, I think, the 60s, and then tolterodine was FDA approved in mid-90s, and then all these came about thereafter. And the beta-3 agonist, mirabegron, was approved in 3 or 4 years now, I think. Much, much newer. So we're going to talk about these a little bit. So I'm going to talk about side effects, because I'm going to go back. These all work pretty well. And they're all fairly, there's not one that clearly is better in terms of efficacy. So how do I make decisions? I make decisions 2 different ways. One is potential adverse events, and the other is cost. When you come into my office and I pull up your record on the electronic medical record, it will show me how much I have my favorites of all my medications. So it's all these medications, my favorites. And it comes up, green, white, or red. Red, I know is going to cost way more. Green's going to cost less, and white will be somewhere in the middle. And since these are fairly similar, we're going to try to make this the cheapest it's going to be for you, because you're already spending a lot of money on other medications probably. We're also going to worry about adverse events. So anticholinergics have a laundry list of dry mouth, constipation, dry eye, skin. We all have dry skin right now with the zero humidity and the fire danger. And cognition, which already has been talked about. Now, none of these things happen a lot at all. I tell patients dry mouth about 15%, constipation is 5%, but may already have bowel issues. Cognition doesn't happen often, but if you're already having cognitive issues, not good, right? So we got to be careful with that. So beta-3s have hypertension, but the majority of patients have no issues with increase in blood pressure, and it's not contraindicated if you're already on a hypertensive medication. We just got to monitor it, but most patients do fine. But there's no dry mouth, no constipation, no issues with cognition. But it's often more expensive, which is why I don't necessarily go to that medication first. So often, certain insurance companies will say, well, you can use the mirabegron, but you got to try others first and fail them. That's what our requirements are. So what if the medications don't work, all right? For you can't snort because you're having a bladder spasm. We can get that. I don't know, right? But now I want to point something out, is that there's a cooler here, so you can put a 12-pack in there at the same time, and it's perfect, right? Or if you're worried about what happens at work, you can do that. But we got to have better solutions, right? Okay, so what else can we do? So what about botulinum toxin? All right? So there's already been talk about the research nurse. So I was involved in the studies that got Botox FDA approved for neurogenic bladder, and we had trials at both USC and Rancho Los Amigos. It was great. And what's interesting it's really interesting, in the initial trials, we wanted to get spinal cord injury patients and MS patients. And if we had a preference, we wanted more spinal cord injury patients because they were stable. And we were less interested in MS patients because they could progress during the course of the trial because it was a very long trial. Because one MS injection could last 9 to 12 months. And that was not the preference. We got way more MS patients because the MS patients are involved, they're in societies, they got the word out, and it was just, and the spinal cord injury patients were clueless. Not clueless, but they weren't, if you weren't at a center that focused on spinal cord injury, it was much easier to involve the MS population. So it's FDA approved for if oral meds fail. What does that mean, fail? It means it didn't help you out enough in terms of efficacy, or you don't tolerate the other medication. So if, say you take oxybutynin, and it works great, but you can't tolerate it because your dry mouth is too severe, that qualifies. Same idea. We do it in the office. I do it in my office with a little cystoscope, which is like a catheter with a little lens on the end. You put it in the bladder and inject small amounts of Botox throughout. Easy. You can drive yourself. You don't need it's local anesthetic only. Depending upon the dose, may last 6 to 10 months. The biggest risk is, if you're not already doing it, is a need for a catheterization. And I could spend an hour talking about catheterization in the MS population, because I'm not sure why, but there is a patient population that I see a lot of that is certain times the most resistant to say, okay, I'm going to start catheterizing 1 or 2 times a day if you think it's going to be helpful. And my theory, my junior psychology theory is that I think some folks don't want to, they think it's an admission that the MS is progressing, that they have to start catheterizing. And my feeling is, well, this is what your bladder is or has been. It means nothing to do with MS progressing. And the majority of patients say, okay, I'm going to catheterize once or twice a day. And they do it like, man, I wish I started doing this years ago. This is so much better. Now, everyone can't do it, and most people don't need it. And again, depending upon the dose we use, it's a 5% risk. So for every 100 patients I see at the lowest dose, 5 need to start catheterizing. And if you need to catheterize, it's usually once or twice a day for a couple weeks, and then if you're voiding normally, you get back to it. So, what about nerve stimulation? We have 2 different kinds of nerve stimulation. Ankle, or through the back, called sacral nerve stimulation. The second one, sacral nerve stimulation, is kind of a problem, because if you put that in, then you can't get an MRI. And those neurologist folks, they like to get MRIs for MS. So we really don't do that in the MS patient population. It's not going to work. So we do tibial nerve stimulation. Here's an example of a patient getting it. You just literally put a little electrode right in the ankle here. And what you do is we do a test stage once a week, 30 minutes at a time for 12 weeks. And if it works, approximately once a month. Although in the MS patient population, maybe a little more frequently. What about catheters? You can leave a catheter in place and use it all the time. I don't love leaving catheters in place. Sometimes that's the only option, depending upon your disability and mobility. The other one that I don't think I put on, I was thinking about this earlier, was for men, it doesn't work for women, we also can use a condom catheter. So a condom catheter is essentially kind of industrial strength condom. And instead of being closed at the end like you would for sexual activity, it has a little tube that then goes to a leg bag. So if you feel these urges and you can't get to the bathroom all the time, or you don't have the mobility to get to the bathroom when you feel that urge, but you don't want to do anything else, just put a condom catheter on, and that just catches the urine. So it's a nice option instead of wearing a diaper or having to change clothes all the time. So you have a 43-year-old woman, MS, pees too much, urgency, can't get to the bathroom in time. You tried some Kegels, fluid management, cut back on your fluids, oxybutynin, that didn't work. Still with urgency incontinence. We did urodynamics, so the true overactivity. That's the study that we do that shows bladder spasms. And we talked about different options. She decided to go with Botox, and done very well. And I have plenty of patients with Botox that we're re-injecting. So if Botox works, you're getting re-injected about every 6 to 9 months. All right? Now, what about a 43-year-old woman? Bladder symptoms include kind of very similar. Pees too much, she feels the urge, can't wait. Can't initiate void without an urge, though, a little bit different. She can't go unless the urge occurs. But she got something a little bit different, her residual. So that little machine we put over the bladder, after she went, essentially is a volume equal to a can of Coke in there, which essentially is a very normal bladder capacity. So her problem really isn't can't store, but she can't empty. Can't empty. A little bit different, right? I don't want to give her those meds. Those meds relax the bladder. I relax the bladder, this problem's only getting worse. That's why the neurologists at USC have a machine like this in the office, so they can tell the difference. So what does that mean? So if you can't empty, it means you're leaving too much urine behind. And that's either because your bladder can't mount that contraction you need to empty. Now it's two ways. It means it may not be strong enough, or it may be strong enough, but it may not continue until you're empty. Or downstream from the bladder, there's blockage. So what's the most common reason people are blocked? Well, it's 50% of the population is men. We have prostates, and prostates grow. Okay? But a little bit different with MS. I mean, it could be a man with an enlarged prostate, but there are other reasons why bladders don't empty, and usually it's not just because of a big prostate. That's where, again, urodynamics are helpful. So how do we help with that bladder that can't empty? You can do intermittent catheterization. It's kind of what I alluded to before. You know, most folks can void some. Most of our MS patients aren't in what we call retention, meaning you can't pee at all. You can pee, but you don't empty out completely. So what we do is say, look, let's say you're getting up 4 times a night, and that's really bothersome, and you're leaving 360 like this patient. What if you pass a catheter in the bladder, get your bladder completely empty, throw the catheter in the trash can. You don't leave it in. Now your bladder is empty. You're going to sleep all night or get up once a night. Way better if you can do the catheterization. So you pass the catheter in and out to empty. And again, it's easy if your hand function allows it. And you're, you know, it's different for men and women. For guys, it'd be very easy to find where you're catheterizing. For women, especially based on your level of ability, disability, getting to the urethra can be very, very challenging. It may not be possible. We know that. Our nurses are very good at working with our patients and caregivers and family members, trying to help with catheterization, teaching techniques. Everyone can't do it. We know that. And depending upon what's going on, we may combine that with medications that help relax the bladder as well. This is a picture of a suprapubic tube. So if you can leave a catheter in all the time, if we're going to leave a catheter in all the time, I don't like leaving it in the native urethra, in your urethra. I'd rather just have it, so the head's up here, legs are down here, head up there. So this is a patient's sweatpants, and there's a tube just coming out of the lower part of the belly. Has a bag, drains all the time, has to be changed once a month. So we tend to do this when things are a little more they've progressed a bit along, and there's more issues with mobility, hand function. It's a great option, but it's not my first option. I'd rather not have a catheter in all the time if we don't have to. I talked a lot about meds that can turn the bladder off and relax the bladder. We don't have meds that can turn the bladder on and make it contract. This doesn't work, unfortunately. We can do medications for the prostate, but again, that's not often why most of our MS patients can't empty their bladder. So let's come back to our lady who's having issues with frequency because she never empties out completely, has a residual of 340. She's catheterizing 3 times a day, and again, not perfect, but her symptoms are minimized. So you could have issues with emptying or storing, or a little bit of both. There are treatment options for all of these. So we often will treat empirically, based on your symptoms, try medications. That doesn't work, we may do some other evaluation with either a bladder diary, urodynamics, and all decisions we impact level of disability, ability, cognition, hand function, all play a role when we make decisions on how we're going to treat you. And again, you have a voice. I'm not telling you how you're going to treat it. You're going to make the decision. I'm just giving you options. And the goal is if you're doing well, you can laugh at this, which says, urology department, can you hold? Because if you can laugh at this and you can hold, then you know we're doing okay. So, thank you very much.
Dr. Ginsberg, thank you very much. You're all lucky to have this guy here. I mean, I was impressed by this. We have a lot of urologists talking to our programs. This was very, very impressive. So thank you very much.
I'm sorry, I had a word of aphasia. UTI?
So the question was one word, UTI. We actually had a whole conversation about this ourselves over there because it could be an issue, but sometimes it's blown out of proportion more than it should. And here's the challenge: if you have a catheter in place all the time, or you catheterized, you're probably colonized, which means there's bacteria in the urine. And that, I don't care about. That's okay. The challenge is figuring out when do we intervene, because you may always have bacteria in the urine, right? And that's hard. So if you have bladder sensation, all of a sudden you tell me, gosh, that urge is worse, I'm having more issues with incontinence, that's easy. But let's say you have poor bladder sensation, you don't really feel when your bladder is full, and then you're having a little bit of a worsening of your MS symptoms, and the question is that related to a UTI? Is it something else? Those are tough ones to figure out. But yes, when you have a neurogenic bladder, you have an increased risk of UTI. A lot of patients will commonly think that because you pass a catheter in and out, you're just going to be getting UTIs left and right. That's not the case, but there will still be a bit of a risk of a UTI. So yeah.
Great, thank you. Remember, everybody, please try to keep your questions generalized and not about you, but something that the doctors can answer because they don't know your medical history.
Do the urine problems usually run into bowel problems?
So the question about urine problems running into other problems. So here, sometimes, but no. So what are the risks? You can get stones, you can get UTIs, you can get blood in the urine. To give an example of where we've come in the world of neurogenic bladder, not necessarily MS neurogenic bladder. Veterans, soldiers that came back from World War II with a spinal cord injury usually died from renal failure because of their bladder function. That doesn't happen anymore because we know how the bladder impacts kidney function. Now with MS patients, it can be a risk, much less so in women than men, but not nearly as much. So the bladder problems that the other problems we see are more related to urinary tract infections and stones, incomplete emptying, more than, say, renal damage or renal failure.
Quick question for Dr. Ansari. Biomarkers. What do you consider biomarkers of MS?
Okay, that's an excellent question. That's an area of ongoing research in MS. One area that we think of as serving as sort of like a biomarker is the MRI. And what I mean by that is that we have at USC, but at other institutions as well, have high resolution MRIs. And what that means is these are MRIs that haven't been used historically for clinical patients. It's mainly for research, although there's now been an approval for the high resolution MRI scanners to be used clinically. We haven't started that yet because there's a protocol, but looking at the MRI signature for different patients, that can be something that can serve as like a biomarker of how someone's MS is doing. Within the blood, as of right now, there's no good biomarker. There was an Australian group that found a marker in the blood that can be used to help delineate what type of MS that someone has, whether they have progressive MS, whether they have relapsing remitting MS. But that can be found out clinically, and so we don't put a lot of utility in that specific blood test to try to determine whether someone's relapsing, remitting, or progressive, because we can just ask you how you're doing and get a sense of that. So I think that's kind of the latest that I know of in terms of biomarkers.
Great, thank you.
Okay, Dr. Ginsberg, and I hope I'm asking this in a generalized way. On the Botox, I had read that a person could die from Botox, and also it could affect your walking and things. So what is your opinion on that with MS patients wanting to stay alive or might have trouble walking, of them walking, or is it hard to?
So that's a great question. So I'm glad we can kind of hopefully put that to rest in this room. So the issues with Botox leading to really bad outcomes really focus more on pediatric kids treated with really high volumes of Botox for cerebral palsy. I'm talking about 500 or 600 units. So we use 100 to 200 units, and you are all adults. So what do we worry about? So you're not. It would be. I'm injecting the bladder. You have to be really unlucky that every little injection I did in the bladder got in the arterial system, which is not going to happen. And even with that, it would be highly unlikely that it's going to impact your ability to walk or breathe or lead to more significant morbidity and mortality. The biggest thing to really worry about, I'm going a little more detail, is if you have MS and you have a neurogenic bladder and we're going to do Botox and you don't need to catheterize now, is will you be okay having to do catheterization because this may work so well, and I say that it works too well, and now you can hold a bunch, but you can't empty it. And you need to catheterize to get the bladder empty. So if you're able to catheterize, it's no big deal. If you can't catheterize, that's a big deal. So.
What about the people that's highly allergic to that?
You gotta wait.
That's an easy one. The question was about allergies to Botox. It's very unusual. I don't know anyone that's actually. I'm sure there are, but it's not very. It'd be very unusual to have that problem.
Thank you.
Yeah.
So I appreciate that you talked about ultrasounds and non-invasive procedures to check the bladder. I'm wondering, is urodynamics, is that similar to when a doctor says I'm doing a biopsy on your bladder?
So a biopsy means putting a scope in the bladder and then getting a piece of tissue so then the pathologist can look under the microscope at that tissue. Urodynamics entails putting a small pressure reading catheter in the bladder, and oftentimes a small pressure reading catheter in the rectum as well. People are like, ugh, that's terrible. It's like having a rectal exam and you forget it's there while the study's going on. And then we have you sit in our little toilet that measures the flow, and we fill your bladder up and just recreate what happens at home. So there's nothing invasive as putting a catheter in. We are not doing a biopsy. It's getting function of how the bladder is.
So biopsy is the last resort then, right?
There's no reason to do a biopsy on someone with a neurogenic bladder unless you're worried about a bladder tumor, really. Yeah.
Dr. Ansari, I understand the excellence of a comprehensive care clinic, but if there is none in your location, what do you suggest?
That's a really good question. One thing that I didn't mention that was in my notes was that some places don't have a comprehensive MS center, within even like hundreds of miles. And so when you live in a place that's as far away from a comprehensive MS center, what can you do? And I think that this is where it's important to have multiple providers. And so what you can do is that with what happens with some of our MS specialists at USC is they'll see their MS specialist maybe once a year, maybe even less frequent than that. They'll make a trip out, they'll try to coordinate their care so that they can see multiple people, whether they're in a research study, if they're also seeing the physical therapist, or if they're also seeing the neuropsychologist. They'll try to arrange all of their appointments at the same time. But then they'll have a local neurologist where they live. And that'll be someone that's in contact with the MS specialist and can help guide some of the care a little bit better so that you still have the benefits of your comprehensive MS center without having to make a lot of trips out there. It doesn't work for everyone, but that's probably the best way to go.
My question is for Dr. Ansari. In the extended comprehensive team, I noticed you didn't mention a podiatrist or a vocational rehab therapist. What is your thought on that?
Yeah, the bubbles for my extended team, I only had limited space, so I wasn't able to include everyone. I didn't include ophthalmology, I didn't include nutrition, which are all very important parts of MS care. With regards to podiatry and vocational rehab, I think those are are important. I think not every MS patient necessarily has to see a podiatrist, but I think it's very important, especially when you're dealing with symptoms of neuropathy or myelopathy, where you don't have feeling in your feet or in your hands, to have that kind of impact. And that's something I haven't thought of in a while. So I think that that's something that is very important to think about, and foot health is also very important in MS, just like with diabetes. With regards to vocational rehab, that's something that we will sometimes refer people for, but is not something that I've had a whole lot of experience with as of now.
Thank you. I have a question. I just heard about drug companies, or actually about a bill probably coming out where drug companies will no longer be allowed to offer copay assistance. Can you speak a little bit about this?
So I can't speak in too much detail about this. I only know what I've heard from our MS pharmacist. Again, and this is where she's been a very valuable resource. I believe that there's a bill that is supposed to come into effect in January affecting generics. And so I think that that's the only thing that I've heard about, is that it may limit the individuals who are on certain brand medications if there is a generic available. But as far as the prescription assistance programs, I'm not familiar with that being limited in the particular bill that I'm speaking of. You may be speaking about something else. Mm-hmm.
Next question here.
This is a question for Dr. Ginsberg. You mentioned hesitancy, and I'm not sure whether I missed it or whether that was something that had relatively little attention. I wonder if you could address that, absent the prostate issues. What sorts of treatments are available, and what are the issues that you would be looking for?
So let's look at it in terms of what we call obstructive voiding symptoms. So voiding symptoms that would suggest there's some blockage downstream, and that includes hesitancy, urine doesn't start immediately, poor flow, incomplete emptying. So if there's not a prostate, it's either because the bladder isn't generating enough force or isn't starting when you want it to, or the bladder is working fine, but your own sphincters downstream aren't relaxing. So we have sphincters downstream that keep us dry. So normally when we walk or if you exercise, you don't leak urine. And they're always on, except when it's time to empty the bladder. And without us thinking about it, the bladder contracts and these sphincters downstream relax. With MS, depending upon where the lesions may be, that bladder is still contracting like it should, but your sphincters downstream are not relaxing. So your bladder's working against a blockage that would be like a prostate blockage, except there's no prostate there. It's just the sphincters aren't relaxing appropriately. We can try some medications that can at times help that, but not always. And so we have some medication, like medications you would use for the prostate.
Dr. Ginsburg, with men with MS, do they tend to have more problems with the prostate as well, especially as they tend to age?
I don't know of nothing that would suggest that a man with MS is going to have more problems with prostate enlargement. Men with MS are going to have more bladder symptoms. I think it's really more related just to the bladder itself, whether it's the bladder being overactive or the bladder not giving you a good contraction, or that's what we call sphincter dysynergia, that sphincter not relaxing like it's supposed to. That's really the more common reason. Yeah.
Okay, Dr. Ansari, you had mentioned Leslie Tarot, and I want to say she is the most excellent practitioner for a question, and to be commended with a very good teacher, Dr. Brandis, and I know she answers a lot of questions and is to be extremely helpful. I'm sorry.
I concur. I definitely agree with that sentiment. Thank you.
Back to the other side of the room. One moment, please. I'd run, but I might fall and then hurt my thumb again.
Hi, my question is, I just want to know your perspectives on what I'm doing right now. So Dr. Berkovich, she put me on, like when I used to go see her, Emperor, however you would like to pronounce it, Empura. And it was not for gait. Though it was put on the market for gait, she gave it to me for brain fog. And I wanted to know if there was any other medications that I could look into regarding that. And I don't know what your terminology of brain fog is, but I'll just spaces between words and sentences.
Okay. So I think there was a little bit of multiple aspects of the question, but I'll try to address each one as best as possible. So with regards to brain fog or cognitive dysfunction in MS, I want to stress that it's a multifactorial process. It's not one thing that's going to help you get through those symptoms. You want to address any what we call confounding factors or any other symptoms that might be contributing, whether there's any depression there, whether there's fatigue is limiting why you're not able to think as clearly, whether sleep. Sleep is so important for overall health, and when you're dealing with pain, when you're dealing with nocturia, waking up in the middle of the night to go to the bathroom, it's hard to get a good night's sleep, and that can definitely impact the best of us in terms of being able to think clearly. And then on top of that, if you have MS, it just makes things more difficult. So addressing those individually as much as possible. With regards to Empura, the only thing I'll say is that the way that Empura works, just to kind of simplify things, is that it tends to sort of help prolong the conduction that happens in our nerves. And so by doing that, the idea is that any area where there's a conduction problem, where the nerve isn't firing as well, if you prolong the conduction, if you prolong the action potential, basically the electricity that's going through the wire, that you may improve those symptoms. And so it's been approved for gait symptoms, but I think most MS specialists think that it could also help with other symptoms.
I think you kind of answered my question off in there, but I know you said don't ask any personal questions, but my urologist problem is a personal question, but I with frequency, if I try to hold it, then I'll get like numbness in my hands. That's one question to the urologist, and another question to the neurologist is what you said earlier. I think the urologist said earlier about based on where your lesions are. So based on where our lesions are, you can tell what symptoms we might have or what we can come up with, and so the doctors should monitor the lesions and how we're progressing in our MS. Do I understand that that's the whole ball game of our disability and how bad the lesions are when they're active and all that stuff? If you guys understand my question.
So I'll go first and let you go. In terms of lesion location can impact how your bladder behaves. I'm not looking at MRIs. That is not MRIs of the spine and the brain. That's not my area of specialty. I mean, I know what how the bladder is gonna misbehave with MS. We know that there are different patterns you see with lesion size, lesion location. But for us, we still often have to do urodynamics if things don't improve with appropriate medical therapy, and then that tells us exactly how your bladder is misbehaving. And so I rather do the urodynamics because that tells me. The MRI may be helpful, but the urodynamics tells me for sure. In terms of your tingling, that just makes me think that you may be having some bladder spasms again. And again, that's where urodynamics can be helpful if you're not getting adequate improvement with medication. So, we really I think to me the take home is we really in urology rely on urodynamics when things don't go the way you and I would like it to when we try medications or catheterization or physical therapy or something else or all the above.
And then to address your other question with regards to where the lesion's located and what type of symptoms you might be having, in neurology, the thing that we learn at the very beginning of residency is localization. Finding out, depending on what symptom you're having, finding out exactly where in the brain or the spinal cord or the nervous system that you're having a lesion or an attack. In MS, it's not quite that simple. It's actually very difficult to localize where the lesion will be based on a symptom someone's describing, but there are some things that can help us distinguish that. So one sort of mantra that Dr. Pelletier, who's the head of the MS division at USC, has taught me, and that I think is a useful way to think about things is, MS thinks with the brain and walks with the spine. That's kind of this mantra that he's taught me, and there's so many other symptoms that you can talk about that can fit within that. But, if you're having more cognitive symptoms, if you're having more difficulty with speech and things like that, that's going to be more related to lesions in the brain. What part of the brain, that can vary. If you're having slurred speech or you're having trouble swallowing, that's usually in the base of the brain called the brain stem. If you're having more issues with just thinking clearly, that's going to be more towards the cortex, which is the outer layer of the brain. And as of now, the typical MRI scanners we have aren't able to detect the lesions that are all the way at the surface of the brain. So that's why a lot of times we'll see patients whose MRIs don't look that bad, but they're having a lot of cognitive symptoms, and we don't know how to reconcile that. Well, the key is that we're going to start using higher resolution MRI scanners that can actually look at the cortex, look at that outer layer, and see if there are more lesions there, which is what we suspect is going to be the case for the patients who have this kind of disconnect between their MRI and the symptoms.
Dr. Ansari, for some of the medications or even vitamins, we know that they work better in combination, like calcium and vitamin D. What do you think about magnesium with vitamin D? Is it a catalyst for the vitamin D?
I haven't heard anything specifically with regards to using magnesium with vitamin D. Magnesium is very interesting. It's been studied a lot in neurology in patients with stroke and patients with headaches. There's some thought that it may have a neuroprotective effect, but specifically with vitamin D, I haven't seen any evidence that magnesium, in addition to vitamin D, can help bring up the levels. But what I can say is that vitamin D is very important in MS. Patients who have lower vitamin D levels, may have more disability and more MRI lesions, and that's something that we take very seriously. So we usually recommend our patients be on vitamin D, and we monitor levels at least every year.
Yeah, I believe my question is for Dr. Ginsberg. I know several people that have had problem with holding their urine, and somebody suggested, okay, go to therapy so as to get the Kegel exercises going. She didn't know how to identify those Kegel muscles, and I don't think a lot of us know how to identify those Kegel muscles. So the option she opted for was to have surgery, and that helped reinforce those Kegel muscles. And I'm wondering, would you suggest that for somebody that has multiple sclerosis?
So if someone has been asked to do Kegels, first of all, if they're asked to do Kegels, they don't do it well, then and they really want to try that, I would highly suggest they work with the pelvic floor physical therapist, because the pelvic floor physical therapist is really going to teach them how to do it well. Now, just because you do it well doesn't mean you're going to get better. It doesn't help everyone. If you don't get better with pelvic floor physical therapy, and then someone did surgery, that means they probably had stress urinary incontinence, which means your friends leak when they cough, sneeze, laugh, exercise. And that, we do great with surgery for that. That is not usually why most of the MS women leak. They usually leak because of bladder spasm with the urgency and urgent continence. Now, look, if you're a 45-year-old woman who's had 3 vaginal deliveries, you may have some issues with leaking when you cough, sneeze, laugh. And then you get MS. So, and then you might have some overactive bladder issues, the urgency frequency. So it's the urologist's job to figure out what it is that's really causing the problem and then focus the treatment for the leakage when you cough, sneeze, laugh, which may be surgery, or focus on the treatment for urgency frequency, urgent incontinence, which may be medications or Botox. So it depends on the patient and what their symptoms are and what really bothers him or her the most. But in general, that's not the kind of leakage that we normally see just because of MS.
Hello. If one wants a second opinion of their situation at USC, which is a great place to go, do you know of any like financial programs where one could, come in there and not have to pay everything? I don't mean pay everything, but if you have a financial problem, do they have programs, for like second opinions and stuff like that?
Is this specifically to neurology or the MS Clinical Care Center? So within USC, I'm not familiar with any specific patient assistance programs to be seen at the MS Clinical Care Center at USC. One thing I can say is that we work also over at LA County. Our MS Comprehensive MS Center is physically located at USC, but some of the physicians within the group, including us fellows and Dr. Berkovich and Dr. Burnett, work over at LA County, and that's a resource available to those who are not in the network for USC, and you're going to get the same access to the same research studies, the same research coordinators, and also the same MS specialists at least within that group over at LA County as well.
And Margaret goes to Rancho too. There's also Rancho Los Amigos. You don't have all the support, but they still have Rancho Los Amigos. So.
Two comments, quick comments. My insurance company won't pay for Ampyra because I don't walk. So they'll pay for 4-amino. I go to a compound pharmacy for 4-aminopyridine, and it makes me feel better. But I've been doing that for years. And also, I'm 95 years old, and I've been taking Botox for 1.5 years. Just look at me. But the Botox works very well for me. That's all.
Any other questions? Anybody have any questions? I know there are a few people that were asking that they ask you something afterwards, so if you guys can stick around, that would be great. And also, before I take this question, for anybody leaving, we do need the seminar evaluation forms, so please fill them out. Make sure you fill out everything on there. If you want to say something negative about me, that's great, but I won't respond.
Dr. David, is there any reversal to the suprapubic catheter?
Sure, we just take it out. If there's a suprapubic tube, you take it out, and then the problem is it's challenge, not a problem really. The challenge is trying to figure out what your bladder is going to do if you have a suprapubic tube. So the analogy that I always use is if you have a tube in, so you're draining urine all the time, then you're like someone who's been on a hunger strike, and your stomach has shrunk, right? And if I bring you to the all-you-can-eat buffet, which looks great when you're on a hunger strike, and you take 2 bites of food, you're full because your stomach has shrunk, and so your bladder has shrunk. But over the course of a couple days or whatever, the bladder is going to expand back out, and then we got to figure out where your bladder's natural state is now, and evaluate what's going on with the bladder once the tube is out, and then we figure out what we're going to do to treat it. But you can't do it until you get the tube out and then figure out what's going on.
Okay, thank you.
Any other questions? You have a question? Ugh.
Those of us with MS, and probably everybody, is encouraged to drink water. Drink water. What do we do when we drink and we pee, and we drink and we pee, and we drink and we pee?
So here's, the idea that when I talk to patients, they say, well, they say drinking 8 glasses of water is healthy, drives me bananas, okay? Because if you have MS, your bladder capacity probably isn't nearly the size of the person that said drinking 8 glasses of water a day is good. So then now you're screwed, right? So I don't want you to dry up like a prune, but what I would say is listen to your body. If you're thirsty, drink. If you're not thirsty, don't go out of your way to drink more, because you're going to make an issue that may not be terrible, worse because you're just going to drink more, make more urine, fill the bladder up more often, and repeat that same process of urgency. I can't get there in time sooner than you need to. And again, if you don't drink enough, you concentrate the urine, and that's not so good either because that can be irritating to the bladder. So again, listen to your body. If you're thirsty, drink, but don't go out of your way to go crazy and drink. And you should be at a good, happy medium where you need to be.
I have a question for you concerning especially those here in LA with all this traffic. Now they have to go. They're stuck in the middle of 405 and they got to go. What do they do?
Well, hopefully you have your bladder under control that you're going to do okay. But I mean, people tell me all sorts of contraptions they keep in their car. But that's, probably not, we can't text and drive. I have yet to see the law that says you can't pee and drive. But that's probably not recommended, right? Yes, it is. Much harder for the women.
So are there any other questions out here? Questions? Not, you can't talk until I get there. Nope, you can't talk till I get there. You can't talk until I get there.
Oh, yes, I can. Myrbetriq, was that on your list of P medicines?
Yes.
I was using that before Botox, and I thought it was effective. What do you think of it?
No, it is absolutely fine. My comment about Myrbetriq was, what I like about it is there's no dry mouth, no constipation, no cognitive issues with the brain and the fog. But it tends to be more expensive depending upon your insurance coverage, and for some patients that can be a problem.
He used that when he was 94.
Okay.
I do want to thank you all for coming, and please remember, thank them for doing what they did today. Awesome job. Thank you. Okay, again, everybody, thank you for making this another great program.